You should be all set whenever you're ready.
Well, good morning, everyone. My name is McNeil. I will be talking about and going through some research and research articles that I had found related to chronic kidney disease and the 2020 updated KDOQI guidelines, specifically for energy requirements. So I'll go through my purpose for diving into this particular topic, a brief summary of chronic kidney disease, the guidelines for energy requirements, the recommendations from KDOQI, as well as the research articles, any takeaways, and then questions at the end. So I chose to go into CKD, chronic kidney disease, just because it was one of those topics that I felt like I didn't have a whole lot of knowledge or experience in, and didn't really have the opportunity either during undergrad or anything to really dive into and research. So I thought this was a good opportunity to learn more. And then when I was at my main MNT rotation, the dietitians were discussing how they had just recently kind of gone over those new guidelines, implemented charts and documents as far as implementing those into their clinical practice. So that just kind of sparked my curiosity. And so I chose to dive into those guidelines in addition to learning more about CKD in general. So chronic kidney disease, as we abbreviate as CKD, it's the irreversible loss of kidney function. And this is a gradual and progressive loss. It's measured by the glomerular filtration rate, which proportionally goes along with those stages of CKD. So stages 1 through 5, the earlier stages being a little less kind of worse off, if you will. In the later stages, that's where that loss of function is more prominent and definitely more of a hectic on the body as well. And that's going to have a lower glomerular filtration rate in the stages 4 and 5 versus the earlier stages, which will have a higher glomerular filtration rate. So treatments, they are going to vary depending on what stage of CKD a patient is in. So earlier stages, we say more so monitoring of labs, nutrition status, things like that, and just trying to prevent further loss of function. Kind of also going along with other comorbidities that they may have, like diabetes, if they have any other disease states like that, trying to kind of alleviate those other symptoms as well, because those can also help or further their loss of function. So kind of a whole rounded picture there. Once we get to more stages 4, 5, especially 5, we're looking more at renal replacement therapies. So hemodialysis, peritoneal dialysis, possibly kidney transplant, those different therapies would be implemented at that point there. And nutrition implications, they're going to change as well and vary as well depending on the stages of CKD, as well as what treatments they're receiving, whether that's dialysis, a transplant, so that's going to vary. So NKF, KDOQI, a lot of letters, but basically what that is that's the National Kidney Foundation Kidney Disease Outcomes Quality Initiative. And this is a guideline that's evidence-based and goes through nutrition implications related to kidney disease. It's been around since 1999, and the first guidelines were published in 2002, and they were not updated until recently, last year in September, they were published. So there are a lot of other guidelines other than the energy requirements as far as, protein, vitamins, minerals, but for the sake of my specification on the energy requirements, I did only include those guidelines here. So looking at the old guidelines from the 2002 publication, CKD stages 1 through 5 and post-transplantation didn't have any guidelines. As opposed to now, they've implemented kind of a wide range of calories or energy intake, 25 to 35 kcals per kilogram per day. That is also based on other factors such as age, gender, physical activity, if they have any weight goals, and other comorbidities or disease states that they may be in as well. Then we get to CKD, end-stage renal disease or ESRD, whether they're on or not on a dialysis treatment. And the old guidelines, they broke it up into different age states or age groups. So less than 60 years old, they had a higher kcals per kilogram of 35. And then if you were older than 60, they had a little bit more of a range there of 30 to 35. In the new guidelines, they've kind of just done away with the age discrepancy there and just kind of went for one range for everyone. So going through these research review articles that I did find in relation to energy requirements and chronic kidney disease. So this first one is actually fairly new. It's the energy requirements for elderly CKD patients. It was actually just recently published this year. And the purpose of this study was to assess elderly patients with CKD's energy requirements using objective measurements and comparing those to predictive equations that we use in clinical practice, like the Harris-Benedict, Schofield, Mifflin-St. Jeor. So this was a cross-sectional study, fairly small sample size of only 67 patients, and they were elderly patients aged 60 to 86 years old. They had to be in CKD stages 3 through 5 and not on any dialysis. They were also supposed to have a low physical activity level, so a fairly sedentary lifestyle. They excluded any pretty serious diseases such as severe cardiac failure, respiratory insufficiency, cancers, dementia, psych and neurological diseases, and inflammatory systemic diseases as well. So they were fairly quote unquote healthy CKD patients. This was done in the outpatient clinic setting. Each patient underwent indirect calorimetry, which we know is that gold standard measurement for energy expenditure. They also, at that same time, their energy requirements were estimated using those predictive equations. So the Harris-Benedict, Schofield, and Mifflin-St. Jeor were all used in this study to estimate those needs. Accelerometry was then done for 3 consecutive days. The patients wore an armband and were just told to go about their normal daily activity. And then they also were expected to have a dietary record of 3 consecutive days and have a follow-up appointment with the dietitian after those 3 days as well to go through that. So what they found in this study was that when the indirect calorimetry was compared to those predictive equations, consistently across the board, those predictive equations overestimated the patient's energy needs. So indirect calorimetry significantly predicted a lower energy requirement for those patients. And then they took the same data and compiled it to compare it to the KDOQI guidelines of 25 to 35 kcals per kilogram per day in that earlier CKD stage group. And again, that indirect calorimetry comes out lower than even those recommendations, but those predictive equations fall right into that recommendation. So in conclusion, this data is supportive of the proposed guidelines for decreased energy intake of that 25 to 35 range for those earlier stage CKD patients. Additional decreases may also be acceptable and applicable depending on the age, such as this cohort of patients, they were sedentary and elderly patients, so they may have needed a little bit less of a calorie intake. This study did use indirect calorimetry and accelerometry as objective measurements. So again, kind of that gold standard, which I thought was definitely a strength. It was a fairly small sample size, and it was only done at one center. And again, these patients were quote unquote healthy CKD patients. So, you know, kind of widening that range and including different disease states would definitely be needed for further studies. All right, moving on to the next study, I found energy requirements of patients undergoing hemodialysis, a cross-sectional study in multiple centers. So the purpose of this study was to estimate energy requirements of hemodialysis patients and then determine the factors that affect the energy requirements in those patients. Again, a cross-sectional study. This one broke it up into different groups. So the experimental group was the hemodialysis patients, and then the control group were general patients that didn't have CKD. Everyone was 20 years or older, and for the hemodialysis patients, they did have to have treatment 3 times a week for at least 3 months prior to the study. And the control group, they had to have an estimated GFR of greater than 60 to participate. They excluded anyone with hyper or hypothyroidism, any malignant tumors, those who were pregnant, had amputations, or anyone who was hospitalized within 1 month of starting the study. So here they started out with 255 recruited hemodialysis patients, but after that criteria, and then those who didn't have their resting energy expenditure measured through indirect calorimetry, they ended up with 154 hemodialysis patients, and then the control group as well, with meeting the criteria, only 33 met the criteria. So this was done at dialysis centers and an outpatient clinic in East Asia. Everyone had their resting energy expenditure measured again by indirect calorimetry, and then that was multiplied by an estimated activity factor to obtain their total energy expenditure. Again, predictive equations were used, so Harris-Benedict, Schoenfield, and the old, or the 2002 published KDOQI recommendation equation was used to predict the total energy expenditure for these patients. So they did a Bland-Altman comparative, and they indicated consistency between the predicted equations and measured energy expenditure. They determined then that dry body weight and age were significant predictors of measured energy expenditure, which if we look at our predictive equations, both of those factors are included in our predictive equations already. Harris-Benedict, Schoenfield, and the KDOQI recommendations all overestimated energy expenditure again in these HD patients. And then what they did is they broke up the hemodialysis patients, and they took 33 of them and paired them up with the 33 non-hemodialysis or the non-CKD patients. And they compared them in terms of anthropometrics, biochemical data, demographics, as well as their energy expenditure. And they found that there was actually no significant difference between those who didn't have CKD and weren't on dialysis between the ones that were on dialysis and had CKD. So this table here is just showing that significance of the dry weight and age in terms of using those as in our predictive equations. And then here we can see the control group of the non-hemodialysis and the hemodialysis patients being compared in those different ways, specifically in those energy requirements. There was no significance there as far as a difference. So the study concluded suggesting that 32 kilocalories per kilogram should be used for hemodialysis patients who were less than 65, and 30 be used for those who were 65 or older. So remembering that they were using the 2002 guidelines here, so they did still break up those old guidelines into those 2 different age groups. But those 2 kilocalorie requirements that they did suggest here are still falling within that 30 to 35 range that they have on their new guidelines as well. So supportive there. And then they did also mention that more extensive research may be needed to create predictive equations that are more specific to hemodialysis patients or patients that are in different stages of CKD just in general. The study did have a larger sample and wider age range, as well as a broader spectrum of diseases that they included. So there were patients included that had diabetes, there were patients included that were malnourished, and they compared this with similar studies that were done previously And like the study that we saw before, that was a smaller sample size than this one, even too. And again, those patients were quote unquote healthy. Limitations, again, even though it was larger compared to the previous study, it was still a pretty small sample size. Other factors than the medical conditions that they did include in this study may also need to be included if further studies are done, as those can influence energy requirements as well. And moving on to the final study, estimating resting energy expenditure of patients on dialysis and development and validation of a predictive equation. So this study was very interesting. What they did is they developed and validated a predictive equation that they created for resting energy expenditure in a cohort of patients on dialysis. And they also tested the accuracy of two previously developed equations that we don't really use in clinical practice. They're still being studied. So this was a cross-sectional study. 131 hemodialysis patients were included and 58 peritoneal dialysis patients were included. So they included both different dialysis patients. Everyone had to be 18 or older, and they had to, again, have dialysis for more than 3 months. They couldn't have any catabolic conditions, and they, again, had to have normal thyroid function. No one could be on corticosteroid therapy, immunosuppressive medications, couldn't have any malignant diseases. And I found it interesting that at one clinic, they had patients with diabetes who were on hemodialysis. They couldn't be included in the study. And then at the other clinic, anyone younger than 60 couldn't be in the study. They randomly chose 30% of the patients as the validation group, and then the remaining patients were used to actually develop their new predictive equation. So they did the study in 2 dialysis clinics in South America. Both groups of patients, the peritoneal dialysis and hemodialysis patients, underwent indirect calorimetry, nutritional assessment, and fasting blood tests. The only difference was that they did them at different times. So with the peritoneal dialysis patients, all of their tests were done right after dialysis, but in the hemodialysis patients, the indirect calorimetry and blood tests were done on a non-dialysis day, and then their nutritional assessment was done on a dialysis day after completing their session. Both groups were prescribed a daily diet of 30 to 35 kcals per kilogram and 1.2 to 1.3 grams per kilogram of protein daily. So remembering back to those guidelines, that 30 to 35 is that range that KDOQI recommends as far as patients who are on dialysis. So here we see the 2 equations that they developed compared to the measured energy expenditure from the indirect calorimetry for the patients. There was no significant difference. They found that these equations were valid and gave good accuracy. And here we see the 2 equations that had been developed in previous studies, Weiler and Byam-Gray, and they were compared to the indirect calorimetry measurement as well in these patients. However, for the Weiler and Byam-Gray studies, they only used hemodialysis patients. So in this study, they also excluded their peritoneal dialysis patients and only used the hemodialysis data to compare these equations. So the Weiler equation was significantly higher in estimating the energy expenditure when compared to indirect calorimetry, but there was no difference in the Byam-Gray equation. So concluding, they developed predictive equations that were proved to be valid and have good accuracy. However, they would need to be studied further and, compared to different groups of patients, different comorbidities, disease states, etc. Weiler and Byam-Gray equations, they did present a low performance when compared to the measured resting energy expenditure, even though in the previous data that were shown, the Byam-Gray was consistent with the measured energy expenditure. They did find quite a few biases and just kind of overall low performance when related to different measurements that could have influenced those measurements. So strengths of this study, the sample size was a little bit larger, and they were able to validate both of the equations that they created. Patients were relatively young, and again, they were pretty clinically stable, quote unquote, healthy dialysis patients, which may not be representative of most of the patients who do have CKD. So overall, each study did support those new guidelines for energy requirements, proving the need to incorporate these into our clinical practice, but also using clinical judgment as far as, like we saw in the first study with the elderly CKD patients, kind of taking into account their activity level, their age, in predicting these energy requirements. Predictive equations overall consistently overestimated the energy requirements. So again, taking that into consideration in clinical practice as well, maybe not totally going into that range of the predictive equations, knowing that they may have a lower energy expenditure. Indirect calorimetry, again, that proves to be that gold standard for measuring energy expenditure, but it's very impractical in the clinical practice. It's expensive and it's not widely available, so we don't really use it. So predictive equations are our go-to. So again, taking that into judgment as well. And due to those previous 2 points, they indicate a need for development of these CKD specific energy requirement equations, like the previous study did kind of prove as well. So further research should be done about that too. Any questions?
Yeah, so for anyone with questions, feel free to chat it into the box, or if it's a lengthier question, feel free to unmute yourself and ask Sierra as well.
Okay, so Jasmine asked, was there anything in the outcomes of the articles that surprised you? I guess I was surprised that the predictive equations consistently overestimated energy requirements, just because we do use them in clinical practice so often. It was pretty surprising that those do overestimate. So it just kind of made me think that, oh, maybe when we do see these patients in acute care, we don't necessarily have to go strictly in those ranges that we estimate. We may need to take into consideration their age, their energy level or activity level, things like that. Any other questions?
Well, I'll kind of start wrapping it up. If anybody has a last minute question, again, feel free to chat it in or interrupt me to ask the question to Sierra. Right now, I'm dropping in the presenter survey. Again, if anybody missed it the first time or came in a little late, feel free to fill that out as well. And then our next presentations will begin at 10:25. So you guys got a little bit of time before those begin. It's going to be Madison. She's going to be presenting on the interventions for cancer. And then Katrina will be presenting on gut health and irritable bowel syndrome treatment. To make it a little easier for everybody, I can drop those links into the chat as well. Otherwise, I can stop recording and then you guys can head over to the next set of presentations.
Thanks, Heather.